Ambassador Eric Gooseby, who's the UN Special Envoy for tuberculosis. I promise that we will keep this hour to an hour. I also promise to engage you in a really interesting topic. We're very grateful to have two continental TB experts. Over the next hour, what I would like to do is discuss with you some of the key findings from the Lancet Commission report that was published earlier this year. And then we'll hear about Nigeria's response to the TB epidemic. Then from Dr. Sematala, how implementation science approaches can help us solve this. In California, does not need a visa to pass into Nigeria. And so, as with other parts of the world, this is a huge problem. In 2017, tuberculosis was responsible for 1.6 million deaths. Unfortunately, despite that political will several years ago, that is not the case. And if you compare the rates of decline in TB deaths compared to the rates of decline in other leading causes of death, particularly other infectious disease causes, that decline at 1.4% decline in deaths each year is just simply insufficient to get us to that 2030 target. And in fact, based on current rates of decline, a 90% reduction in TB incidence won't be by 2045, none of the countries in Africa will have achieved those 2015 targets that were outlined by the NTB strategy. So why haven't we made progress? This is a treatable, curable disease. Everybody who goes to medical school and nursing school knows how to treat TB. Well, unfortunately, it's complicated, right? And there are many factors that have led to this not being an epidemic that we've been able to solve. For some time from diagnosis and treatment, and in addition, patients are often required to pay exorbitant amounts of money for what should be a free treatment. All of these things impact the quality of care. Moreover, and interestingly, many people access care in the private sector. They determine that it's more convenient to go to the private sector, or they go to informal settings in their local communities. Unfortunately, many of these places are unable to provide high-quality care, and certainly using TB appropriately. And in fact, there's a number of really interesting studies, one done in India, another done in China, another done in Kenya, all using simulated patients, walking those patients into TB clinics, into private practices with textbook TB diagnosis and being mismanaged. Only about 28 to 40% of the time in those studies were providers accurately managing TB. In addition to poor quality care, though, there has been a chronic underinvestment of TB globally. The Global Plan to End TB estimates that $730 million a year are spent on TB research and development. And the reasons for this, it's not a sexy disease. There's a lack of financial incentives for big pharma and drug development companies. Furthermore, some of these trials take a long time and they cost a lot of money. And in addition, many of the countries that are best poised to pay for these kinds of studies haven't got a sufficient burden of TB for there to be a substantial demand. And historically, there's also been minimal civil society engagement to advocate for greater funding for TB. The informal sector, which is the top red bar, that's where many people, in this example in Kenya, are presenting for care. Unfortunately, the places where they're able to access diagnostic capabilities are not matched with where they're presenting. Furthermore, when they are appropriately diagnosed, many of them are not able to get the treatment they need, and that's the bar on the far right of the slide. So services are just not being provided in the places where patients are accessing care. Moreover, sorry, skip forward a slide. Moreover, in this study in Lesotho, what they did was they looked at where the services were being provided, and they did something called a network optimization analysis, leveraging techniques from the manufacturing industry to try and determine whether there was a better, more efficient allocation of diagnostic resources. And again, I don't want to go into too much detail here, except for to say that in Lesotho, rather than buying an additional 13 diagnostic machines to diagnose all the TB that was out there, if they just moved those machines to certain parts of the country, they'd be able to save money and diagnose the same number of cases. But it's not just about the misalignment of services. Many patients prefer to seek care in the private sector. And this may well be the case in Nigeria. In fact, in 7 of the highest burden countries, preponderance of people are presenting for care in the private sector. And so that raises the question, how can we better engage the private sector to deliver better patient care? And in the Commission report, we identify a number of strategies that could be involved, that could be employed, and really urge for a frame shift in how we think about engaging the private sector, rather than a threat to public services, but rather a partner that we should engage with, and maybe a partner that should also be considered for receiving donor financing to support their efforts. And so we provide several suggestions around how to better engage the private sector to improve outcomes for patients with TB. Additionally, in our analysis, we demonstrate that if you were to deliver better patient services, if you were to align diagnostic capability with where patients are accessing services, in countries like India, where there's a high burden of TB, or Moldova, which has a high burden of drug-resistant TB, that would have a substantial impact on TB mortality over the next 15 to 30 years. And the key message here is that scaling up evidence-based and identify those individuals that are high risk for tuberculosis who would benefit from TB preventive therapy and aren't currently getting it. We've known for the better part of the last decade that TB preventive therapy for people living with HIV saves lives. No doubt about it. We have a wealth of strong empirical evidence to support that. And it's estimated that globally there are 30 million people that would benefit from TB preventive therapy. Unfortunately, right now, that isn't the case, and I think another strong recommendation is to ensure that TB preventive therapy is made available for those individuals at highest risk. For analysis, looking at using transmission dynamic modeling to sort of try and capture the impact of an increase in TB preventative scale up in Kenya and South Africa, we demonstrated that those things would have a substantial impact as standalone interventions on ending the epidemic in both of those countries. Priority number 3, though, is about increased investment in R&D. And the plot, 50,000 deaths a year, that could be averted if there were more effective diagnostic tools available. And so I think a key message from our report is the need for increased investment on the whole spectrum of TB-related research priorities. And I've highlighted here the importance of basic science, but also something that Dr. Sementara is going to speak on is the urgent need for implementation science. What is going to work in San Francisco is clearly not going to work, or not necessarily. The importance of the crucial importance of research that was specific to each context, and in addition, building the capacity of the next generation of researchers to address those questions, especially in Africa, where the burden of TB/HIV is so high. One last thing about TB R&D. I think I'm speaking to a room of academics who understand the importance of research and development, but for ministers of health and civil servants, the other key thing to emphasize is disproportionately beneficial to the poorest members of society. TB, as you all know, is a disease of the shadows. It's a disease of the most marginalized members of a society, and investing in TB R&D is one way to pull those people out of poverty, or rather prevent them from getting into financial catastrophe in the first place. My battery is failing. So I mentioned at the beginning that there's a link to suggest that if you got all of those countries to increase their commitment to R&D based on their GDP, and then you match that with a matching scheme from high-income countries, we could generate around $300 million extra a year. In addition, I think there's a persuasive argument for the private sector to engage in TB R&D more substantially than they have done today. And there are a number of interesting pull-push mechanisms that are discussed around how you could motivate the private sector to engage in investing in developing new TB drugs with the promise of a hefty prize if they develop a successful drug. Unfortunately, and this is a conclusion from our paper, the inescapable reality is that high-income countries must continue to contribute towards TB R&D if we're serious about ending the epidemic. And in fact, from an economic point of view, investing in TB more generally is a no-brainer. And this is a monograph that was published in the Lancet a couple of years money. For every single dollar invested in TB R&D, it's estimated that there's a $54 return on investment. And so in the report we highlight this, we emphasize the value of benefits from averting deaths from TB exceeds the cost of over fivefold. And failure to address the epidemic over the next 30 years will cost the global economy terribly. And in fact, we use some modeling from India to illustrate that for every year that India is unable to close its gap between the NTB targets and where they're currently at, will cost the Indian government $30 billion a year alone. The other thing that we emphasize in the report, though, is that there needs to be greater shared responsibility. Is the potential for greater domestic resource mobilization. Again, something that we heard in the last session. Many of the highest burden countries could potentially increase their domestic resource allocation to tuberculosis by prioritizing TB services within their health system, by increasing sin taxes, we heard about tobacco taxation earlier, by increasing or improving revenue generation, and by pooling resources from across the health sector. And in the example we highlight that in a country like Zambia, they can actually increase their domestic investment. Financing comes from domestic resources. But in the lowest income, highest burden countries, donor investment remains crucial. And the good news is that actually there has been a massive increase in donor investment in TB over the last 30 years. Back in 1990, there was only $30 million spent on TB globally. Now, as of 2017, there was $930 million spent on TB by donor partners. However, and this is a point to pause and reflect, many of the countries that are currently recipients of that donor financing are countries that are where their GDP is increasing and they will soon become less eligible for TB funding because they are they're about research analysis to try and help answer that question. I think the key take-home message for today is that those countries remain uniquely vulnerable. As they approach transition, there are some specific vulnerabilities that the global community needs to be aware of. So for a start, many of those countries will tend towards choosing lower cost drugs than are provided by Global Fund or PEPFAR sources. And more often than not, those drugs are of poorer quality. So there remains a continued value on market shaping activities to ensure that the best quality drugs remain affordable even to those countries that are becoming less eligible for Global Fund financing. There is also an important role that the donor can play in providing technical assistance to improve the efficiency of existing resources. Men who have sex with men, professional female sex workers. And so in many situations there remains a continued role for donor sources to support interventions focused on those groups, whilst there remains no less domestic will to support investment in programs to support them. So finally, I'm going to end here. The Commission ends with a key emphasis on the need for greater accountability to end the epidemic. There needs to be a recognition of the powerful role that TB survivors and advocates must play, and a commitment to addressing the drivers of tuberculosis, particularly that are affordable. And again, that's something that the report emphasizes. And the busy slide on the right, I won't go into detail, except to show that our analysis at UCSF suggests that investing in TB is a key marker and a tracer of progress towards universal health coverage. So I'll end there with some thanks to my colleagues at UCSF, and then segue to my colleague Fred, who's going to speak about the importance of an implementation framework agenda to end the epidemic. Oh no, I'm sorry, Dr. Lawrence is next.
I want to appreciate the organizers of this meeting for giving us the opportunity to present the Nigerians' commitment to ending TB. I also want to appreciate our minister to see that they really supported TB program. program to this point where we are. Thank you very much, sir. We know that we are here as Africa researchers and educationists. We see that Nigeria is number one as far as TB burden is concerned in Africa. Looking at TB, susceptible TB, and multiple resistant TB as well as TB HIV. By our the estimated incidence, we have a 219 per 100 population, 100,000 population, and in 2018, according to WHO global TB report, we see there the mortality rates. One thing that is very good with our program is that when we find the TB cases, we actually treat them and then what we had as at 2018 was 86% treatment success rate. We have 96% of the notified TB cases documented having HIV documented status, and then we also conducted a research or a study to see spend a lot of their investment, a lot of whatever they have is seeking care for TB. We had that about 71% of such patients actually incur catastrophic, but that is spending to over 20% of their income to find a lasting solution to TB in their lives. TB control strategy in Nigeria. How are we controlling TB in Nigeria? We see that in Nigeria we actually LTBLCP, that is the National TB Leprosy and Universal Control Program, was actually set up 30 years ago. And how do we implement? We implement based on a strategic plan. We actually developed a strategic plan to cover 2015-2020. That is not to say that we didn't have one pilot to 2015 and the universal healthcare coverage. And all this we do based on the WHO's recommended NTB strategy. For TB program in Nigeria is we have the basic management units in the local government. That's all the three tiers of government are actually involved in providing TB services and ensuring the control for these diseases in Nigeria. And the latest of it is the Nigeria's endorsement to the commitment of NTB global strategy, which is the United Nations. The declaration domesticated it and put up a plan, giving the various states what they are expected to do, giving them the targets, delineating roles and responsibilities of the various tiers of government, including our partners. And we had this document developed and put up and signed by our honorable minister here seated. And that has also been presented to the president of this country to see how we can move this forward. What are the steps we've taken to stop the partnership which established and is functioning? And even in this room, like 3 weeks ago, we actually had a meeting to raise domestic resources for TB in country, among the private sector. We also have the first lady of this federation as our TB ambassador, and the domestic resource mobilization committee was set up by our then minister, that is the Professor Adewale. We have at 2 levels. We have one for the public sector and also one for the private sector, because we know that we actually need the resources, because now the donor funding is winding up. And then there is a plan of establishment and inauguration of that committee. In diagnosis and treatment, we've gone a long way. We have the GNS partnership in 305 local government, even though our plan as a government and as a nation is to have at least one in all the local governments. We've had microscopy centers, which is almost 3,000 of them, and this is to aid diagnosis in places where we don't have experts, because the experts is not universally available everywhere, and then accessibility is something like this question. So in order to bridge that gap, we've asked the people at the healthcare facility level to also use microscopy. Microscopy is also very important, because that is what we also use to monitor the progress patients is making when they are on treatment. We have 9 reference laboratories with capacity for 9 pro-acid culture analysis. Only 25% of the cases we are detecting and notifying. In addition to what I said earlier, the childhood TB is also being given a lot of focus. We have pediatricians around the country also providing support for the lower level staff to be able to provide managed TB in the childhood. Knowing fully that to diagnose TB among these children is very challenging, even though we know that there are newer technology that is upcoming to make sure that that is simplified. We have new childhood-friendly anti-TB medicines now that have been put in the system. That is also around the country. And then we have a phased integration of TB into the child welfare services, which has also commenced. So we are ongoing. The unfortunate thing is that because of the way the regimens are made, many of the patients at times they refuse treatment because they have to take injection for about 4 months. But with the new regimen of WHO, which we are actually graduating into in the next quarter, we believe when we have oral medicines for this patient, the uptake will be better. People will be willing to do that. But in addition to that, what we also do is to give a social support to this patient. We provide them the resources, money, support them every month when they are injection, when they are very sick, and then it becomes very difficult. Like I told you, some of them also, because of stigma, and some of them also leave the residence where they are, they go to other places, and with that, we were not able to get almost all of them onto treatment, besides those who actually died before treatment commenced. For the private sector engagement, we know you can't do it all. Science has told us in Nigeria that 60% to 70% of Nigerians seek health in the private sector, particularly very supportive. So private sector engagement is something that we are elaborating on, and we also have a community engagement in the sense that this is to also create demand for the service that is being put out there. TB HIV collaborative activities is also ongoing. This is how far we've gone with TB HIV, because there are two brothers that are called breaking havoc. 97% of the TB patients have documented HIV status in 2018. It's HIV positivity a real problem in providing these services at the facility level. Human resource, because at our adult centers we have all those community issues, they are the ones that are there. Low TB case finding, we cannot find all of our cases. The huge gap in terms of the budget. Like in 2018, we only have 76% funding gap, because majority, the bulk of the money that we use in supporting TB in Nigeria is donor support. For us, as we have what we call, we have a training center in Zaria. That training center, you can see I started. That training center was budgeted with Firebirds, with all the support, and I want to say the minister has also actually helped us to make sure that that is already being put up now. So it was gotten fire last fall. In the technical guidance for the program, they are the ones that are chairing most of our task forces, tax team members. The tax team that we have, we have the charity committee. It is headed by academia. Even our National TB Research Committee is headed by an academia. We also have the support of the implementation of some of these our researches. The catastrophic survey that we did, the KAP study that we did was actually headed by the academia. They are also supporting us to develop research agenda for the program, and also assisting us to make quality of services, reviewing, updating all our research agenda. We are also looking at including TB in the curriculum, the pre-service curriculum. That is very important, because TB is very dynamic. We have a lot of newer information as to how TB will manage successfully. So we want that to also be included. Engagement of other academia and dissemination of program information. Resource mobilization is also under where you can also support us and then optimize.
Thank you for the organizers for giving me the opportunity to present this, and to Mike for inviting me to talk about our work. I should also offer special thanks to Professor Nelson Siwakambo, who introduced me to Strive HIV. So as we begin, I prepared this talk into 3 sections, which I will quickly run through, and one of the implementation studies that we are going to, we are starting soon. And I will try to go straight. So if that graph, if you look at the graph, the national TB rates have been moving between 450 and 480 over the past 11 years. And there was some kind of surge in 2018, which is attributable to a recent survey, which I'm going to talk about briefly. Over 60% of the TB cases. And the chest X-ray, which is only available in specific sites, only identified 50% of the culture confirmed TB. The HIV co-infection was 45% relative to the general population, which is 6.4. And here to notice that of the TB cases currently, 50% of the confirmed TB is diagnosed by TB diagnostic centers. So those show some of the gaps that exist within the diagnosis and management of TB. And on a global scene, as has been shown, Uganda is listed as one of the countries with the highest burden of TB and HIV co-infection. So what would be desirable, and I think Mike has alluded to this, but just like those who are negative should be started on preventive therapy. And then the other issue is if someone has TB and HIV, they should be started on both treatment within 8 weeks of diagnosing TB. And beyond that, we should have a good follow-up mechanism where we should ensure that they get cured or complete their treatment, and also that they attain viral suppression from their HIV. So what are we seeing in Uganda? In some indices, there is some good progress. For example, most of the TB, if not all, patients who have TB and HIV have been put on Septrin. For example, if you look at TB with documented HIV, we are still below the target. And worse is to do with TB preventive therapy to newly enrolled HIV patients, where we are at 2%. There are recent efforts to improve this, but also there are areas where we don't even have complete documentation of what we are doing based on a recent progress review report. So I'll quickly take us through some 2013 and 2016. We evaluated the role of point of care C-reactive protein, which is an acute phase reactant that can be used. So we used it in screening for TB in HIV, improving efficiency for TB screening and diagnosis, and predicting early mortality among people who are living with HIV. And for this, we used prospective cohort of over 1,700 patients who were initiating at the point of care CD4, point of care C-reactive protein, and the symptom screen for screening for TB and diagnosing TB. And what we found in summary is that the point of care C-reactive based screening detected 89 of all culture confirmed TB. And 94% of all expert confirmed TB. But we also showed that the point of care C-reactive based C-reactive. So the other paper also looked at the yield and efficiency of novel intensified TB case finding algorithms for people living with HIV. And here we evaluated whether the point of care C-reactive protein TB screening could improve efficiency and reduce the cost of intensive case finding. And the idea here is if you screen patients using the symptom screen, what happens is in our population, up to 90% will screen positive. And what that means in practical terms is that you're going to go ahead and expose them to gene expert in a view to find monitoring undergo confirmatory screening compared to the symptom screen. And then after here, the suggestion is that replacing the symptom screen with the point of care C-reactive based protein TB screening would improve efficiency and reduce the cost of intensified case finding among people living with HIV without reducing the yield. So the next paper that which is in press of biotherapy, and I must say here that this study was done just before test and treat was taken up as a policy in Uganda. And what we found was that if you used the C-reactive based protein screening, you would, for every case of TB that were diagnosed amongst the new patients, you would need only 5 cartridges of GeneXpert. We talked to you about our implementation study, and so as we know that TB preventive therapy has traditionally consisted of use of isoniazid, which is taken for up to 9 months. It has been found effective, but it reduces TB incidence by up to 50% and reduces the risk of death or severe illness. However, it has had limited uptake prophylaxis. So over the past 8 years, there has been a lot of evidence to show that there are other more convenient and shorter regimens, particularly the use of rifampicin and isoniazid in combination, which can be used as a weekly dose for 12 weeks or as a daily dose for one month. And so this has been shown to have similar efficacy. This study that we are doing is within an implementation setup to compare the uptake of 3 HP under 3 delivery strategies. We are looking at facilitated directly observed therapy, where we'll have a patient come to the clinic once every week to take their medication. But we're also considering facilitated self-administered therapy, where the patient can take the first dose from the health facility, but take 3 other doses from within the community, and only come back to take their subsequent. And so for the medication, here we are looking at in the intervention components, we have as I mentioned, 3 arms. We have standardized pre-treatment counseling for both the for the 3 arms. For medication monitoring, for the DOT, we will do weekly clinic visits, while for the self-administered therapy, we will use remote electronic monitoring to see if they are taking their therapy, while we will have monthly visits for self-administered therapy. And we've had some initial preliminary study to evaluate the costs associated with this, and also to see what the patients and the providers think about this study. So the setting is the Mulago AIDS clinic, which I head, and it's the largest HIV clinic in Uganda, which is providing care to over 16,000 patients. Look at those 3 arms that have been highlighted. And we are using rifampicin and isoniazid, which will be, which will add pyridoxine to prevent the peripheral neuropathy. So, so far we've completed the formative study, which has informed the reimbursement process for our patients, and also has given us some qualitative knowledge of what people think about this treatment and what to empower them to take this.
Just a quick point before we go for lunch. Please, if you just stay for 5 minutes. Yeah. In our midst, we have the Vice Chancellor of University of Ibadan. We had to fly from Ghana to be at this meeting, and he was supposed to be one of the chairmen for the opening ceremony. His Professor Ibeli Olayinka. It's very nice for him to just welcome us very briefly.
I'd like to adopt the protocol that I imagine was well established. Earlier, I was supposed to be part of the opening ceremony 2 days on an official assignment. But at the same time, I also still like to recognize my boss, the former Vice Chancellor of the University of Ibadan, and former Honorable Minister of Health, the Right Honorable Professor Adewale. You are recognized, sir. So they have been asked to welcome participants to this third annual symposium of the African Forum for Research and Education in Health, which I noticed from the book of the proceedings that quite a number of scientists and scholars from the University of Ibadan are participating in it, as well as our colleagues from the University of Lagos and University of Jos. Then we welcome all the participants who have had to travel from far and near to this third annual symposium. And I understand that for security reasons, this meeting will have been held at Ibadan. But all the same, we are happy that you have universities in terms of supporting early career academic training given to these three universities, Ibadan, Lagos and Jos. Then there's several other grants have been extended to our scholars. And the theme of this conference, which is strengthening health research, education, service delivery for achieving the sustainable development goals in Africa, I think is apt at this point in time. I could see from the 17 SDG goals that at least 4 of them are directly related to health, one way or the other. So on our part, as it's leading the research for knowledge sake, but it has to be geared towards improving the well-being of our people. And I think issues that have to do with health is quite central to this. So we thank all of you for coming here, and we know that over the 5 days that you are going to be brainstorming at this very beautiful environment. I'm afraid this is my first time of coming to this, is it continental or intercontinental? Intercontinental from this meeting. So that those of us in academia can also relate with government as well as other stakeholders as part of the triple helix. So I wish you a successful meeting. Thank you.
Video.